Hi guys, welcome back. The topic that we're going to study now is patient with bradycardia with a pulse. And the first thing is definition of bradycardia, which would be heart rate less than 60. And in an ECG strip that is given to you in the exam, you would be counting the number of large squares between the R and the R waves. Now the formula to be used by you would be 300 divided by the R interval. Here I have already calculated 6 large squares separating R and the R waves. So the heart rate of this patient is turning out to be 50 per minute. And the question arises, should I be treating this patient? Well, the point is, if a patient is asymptomatic bradycardia does not require any treatment. Lots of time in your outpatient department, you might be having an individual who is into endurance sports, like he may be a marathon runner. Now, people who are into endurance sports, people who do this extensive marathons and would be running 42 kilometers at a stretch in a matter of few hours, these patients tend to have a high vagal tone. And therefore, I can say that this is a physiological response of the body to conserve oxygen so that their heart can perform for a long duration. And in marathon runners, even if the heart rate is, let me say, 50, there is no need for treatment. Similarly, you would have also seen a lot of patients of thyroid malfunction, hypothyroidism in your outpatient department. And even hypothyroidism patients tend to have bradycardia, like the heart rate would be maybe in the late 50s, maybe 55, 58. But anyway, it would be less than 60, but there is no treatment that is required for it. So the first message is that you treat only symptomatic bradycardia. If a person is suffering from asymptomatic bradycardia, then we do not need to treat the patient. And then the question arises, what if the person turns symptomatic? What would be the interventions that would be required? And that's the main crux of this particular discussion. Now, I would also like you to be introduced to a new term before I actually start describing what are the symptoms or manifestations of symptomatic bradycardia, I mean, how the patient would present. The new term that I would like you to be introduced to is chemical pacing. See, in our earlier discussions, I used the word chemical cardioversion. Like in PSVT, we do chemical cardioversion with adenosine, or in stable ventricular tachycardia, we do chemical cardioversion with amiodarone. So we have drugs by which we can control the automaticity of the heart, or if there is an abnormal firing present in the heart, it can be controlled with use of drugs. But at the moment, instead of using the word chemical cardioversion, I'm using the word chemical pacing. Chemical pacing basically means that I am trying to increase the heart rate of this patient. One of the main drugs or main weapons that I have to fight symptomatic bradycardia is atropine. But apart from atropine, what we can also use is epinephrine. And apart from epinephrine, we can also use dopamine. So I can say that there are three drugs which I'll be using. I'm not writing atropine because that's obvious, but then atropine, epinephrine, and dopamine are drugs which are useful for chemical pacing. And chemical pacing would be useful for management of a patient who's having a symptomatic bradycardia. Now, let us evaluate what the symptom profile of our patient will be, how would he present to us, and then we'll discuss the interventions that would be required. Every time there's a bradycardia, the cardiac output would become lesser. So my patient would be coming to me with complaints of dizziness. In fact, in the later part of this discussion, I'm also going to describe the various types of heart blocks to you, so the symptoms would remain uniform. Because of low cardiac output, this particular chap, he may not be able to tell you his mobile phone number properly, or he may not be able to recognize his family members, or he might be lying with his eyes closed, too weak to even do any basic tasks. There would be a possible altered mental status in the patient. A lot of these patients might also experience chest pain. Now the question arises, why chest pain in a patient of bradycardia? Then I can say that if the heart is beating slower, then the cardiac output is lesser, the systolic blood pressure is lesser, diastolic blood pressure is also lesser, and therefore the coronary blood flow would be relatively lesser. And this decreased coronary blood flow can explain the manifestations of chest pain in this individual. Apart from this, there might even be pulmonary edema contributing to breathlessness. So let's look at why pulmonary edema can occur in these patients. You see, the heart will beat slower, then there would be pooling of blood in the lungs of the patient. I repeat again, when the heart is beating faster, it's able to clear off the blood which is coming towards the lungs, and thereby we are able to maintain an effective stroke volume. But in this particular patient, because the heart is beating slower, so there is damming of blood, or there is pooling of blood in the peripheral circulation as well as in the lung circulation. And lung circulation being more vulnerable will show manifestations earlier. So mainly it is pooling of blood in the lung circulation, which would explain the pulmonary edema, and then subsequently manifestation of breathlessness in these patients, which would contribute to even difficulty in going to the bathroom, for example. MI, a myocardial infarction that I've described before you in my earlier discussion, which has a bradycardia as inferior wall MI. So there is a possibility that in the multiple choice question that is given to you, he might be actually describing a patient who's having severe chest pain, vomiting again because vagus nerve is involved here, that causes reverse peristalsis. So a patient with Levine sign, then there's a vomiting described, then there is a bradycardia with hypotension, because all MIs usually tend to have a tachycardia with a hypertension, but which MI would be having bradycardia is inferior wall myocardial infarction. And in these patients, because the right ventricle is the one that is affected, because right coronary artery is occluded, so right ventricular failure would contribute to maybe to small sign also described in the question, or he might just say elevated JVP, or he might just say full neck veins in the patient. So manifestations of inferior wall MI could be described in a question as well with respect to a patient who's having asymptomatic bradycardia. Now, once we have evaluated that there is some problem in the patient, I'll obviously be doing a ECG, and let's look at the ECG findings that would be specific for diagnosis of this condition, and then I'll explain to you what are the interventions that would be helpful for management of this patient. Though the ECG is what I've already shown to you, but let me just get the facts right in this case, which is that the first thing that you need to check out for the heart rate is the RR interval. And this RR interval will always be at least 5 or more than 5 large squares separating the R and the R waves. That's the basic point that I want you to remember. Number 35, which is that if the distance between the R, or the number of large squares between the R and the R, is less than 3 large squares, there's a tachycardia. If it's more than 5 large squares, there's a bradycardia present. And along with this, there is a possibility that if there is a heart block present, then even the PR interval in the question might given to be prolonged. This may not be present in all the cases, because there are various types of heart blocks that I'll be describing to you. Like in movements to heart block, the PR interval would remain normal. But just to give a semblance of the fact that I'm having a patient who's having a bradycardia with a slowed heart, I have written 2 intervals which are prolonged, the PR and the RR interval. Now, in this particular case, the first thing would be anyway to maintain the patency of the airway. Once I've taken and secured the airway, maybe if the person's tongue is falling backwards, I can put a Goodell's airway. And once I maintain the patency of the airway, next I'm going to ask my nurse to check out the SpO2 of the patient. Why I'm doing a SpO2 monitoring is because I explained to you that in these patients, there can be even a pulmonary edema component coming up. So I just want to see whether I need to give supplemental oxygen before I start, or along with, atropine, I need to give supplemental oxygen to the patient. Now, my point is, a lot of these patients might be having a pretty severe pulmonary edema. So though I'm writing the word assisted ventilation, my question to you is, in a patient with severe pulmonary edema, how would you improve oxygen concentration, or oxygen, I would say oxygen concentration in this patient? What is the modality by which you would be comfortable giving oxygen to this patient? Because there are various ways, you have a high flow nasal cannula, you have non-rebreather mask. So how would you increase oxygen saturation in this patient? Let me say it's 80%. In patients with severe pulmonary edema, we can be using a tight-fitting face mask, and we can go in for non-invasive ventilation. Obviously, I need to ensure that the person should be at least able to sit up in the hospital bed. If he is unconscious at this point of time, then putting a non-invasive or going in for a tight-fitting face mask would not be recommended, because anybody who's not in his senses, then there's a possibility that he might vomit, and there might even be aspiration. So this will depend on case to case basis. I might have to even go in for intubation in the patient. Subsequently, if the augmented mental status decreases to the level where he cannot secure his airway, but assuming that at the initial part of the illness, if he can secure his airway, I would like to make the patient comfortable by using NIV, use non-invasive ventilation using a tight-fitting face mask. Now, I have already secured an IV access in this patient by this particular point of time, and I will be giving atropine. One of the main reasons why this discussion is being done before you is because the dosage of atropine has changed with the American Heart Association 2020 guidelines. You would be familiar with the fact that earlier the dosage that was required was 0.5 milligrams, but currently says 1 milligram of atropine is to be given. This atropine can then subsequently be repeated also at an interval of about 3 to 5 minutes. but the repetition would only be done in case you find that the patient is either maintaining the heart rate or the heart rate is increasing. Because you see, when you give atropine, the effect of atropine will go away after a few minutes. So if you find that the patient has improved after administration of atropine, you can give an additional dose as well. But then how much can you give at this particular point of time is total of 3 dosages. In the earlier protocol, if you were listening to the older versions in the app, I was saying 0.5 milligram up to 6 times. Now he's saying that instead of 0.56 times, total dose would still be 3 milligrams, but he says instead of 0.5 milligram 6 times, you could be giving 1 milligram 3 times for administration, so that you can improve the heart rate of the patient. But I create a worst case scenario for you, in a sense that I have given atropine to the patient, but the heart rate of the patient is decreasing. He came to me with a heart rate of, let me say, 50. Now it's down to 40, down to 30 as we're discussing it, in spite of atropine, which might have been given once or twice in this patient. Then the question arises, what would be the next best step for management of this case? So let's look at what are we going to do for the best management of this patient, which is that I'm going to put paddles on the chest of this guy, and I'm going to give incremental current to the heart of this patient to capture the heart. What I'm talking about at the moment is not a defibrillation, because defibrillation is used for tachyarrhythmias. Cardioversion is used for treatment of tachyarrhythmias. We're talking about a symptomatic bradycardia. So when I put the paddles on the chest of this patient, what I'm trying to do is electronic capture of the heart, and this would be called as TCP, that is transcutaneous pacing. We have a transvenous pacing as well. We'll talk about that subsequently, but the message here is that if he gives you a multiple choice question where he says that administration of atropine and still there is a worsening hemodynamic status of the patient. In fact, I would like to just jot it down here. When would you answer next dose of atropine to be given, and when would you answer transcutaneous pacing is if there's a worsening in the hemodynamic status of the patient as compared to what was present, let me say 1 to 2 minutes ago, then our decision would be to go in for TCP. Otherwise, we can go in for repeat dose of atropine. If the heart rate is showing an increasing trend, yeah, you can give a second dose of atropine, because I said one dose effect would be gradually wear off. But if there's a worsening hemodynamic status, it is TCP that would be required. Now, the monitor that showed up in the slide initially when I brought this slide to your notice was that of a display of a transcutaneous pacer, where you would be giving currents in increments of 10 milliamperes. Like we turn the knob and we increase the settings from 10 milliamperes to 20, 30, 40. And usually by the time we attain a current of about approximately 70 milliamperes, you would be able to capture the heart. When I say that you will be able to capture the heart, let's look at now how the ECG of this patient will manifest. So I'm just going to move my slide laterally and show to you ECG of a patient who was suffering from a bradycardia. We gave atropine, there was no improvement, so we decided to go in for a transcutaneous pacing or a TCP in this patient. Now, the ECG of this patient is very peculiar in a sense that you can see these vertical lines which are present here. These vertical lines which are present at the moment would be called as pacer spikes. So though, I mean, that word is already mentioned, but just for the color contrast part, I'm writing that once again. Pacer spikes would mean that now there is an electronic capture of the heart. So look at the technology that we have nowadays, that we can electronically capture the heart from outside. I mean, we're not opened up the chest, but we have put paddles. How would you put these paddles? Would be same as you use in an automated external defibrillator, or you use it for defibrillation, which is then one paddle would be on the right side of the chest below the right clavicle, other one on the apex of the heart, that is on the nipple and going towards the left part of the axilla. So standard position of paddles, and we are doing an electronic capture. You can see the pacer spikes, and every time there is a pacer spike happening, you can also notice that there is a broad QRS, or I would rather say broad RS complex, that is occurring. This broad RS complex followed by a small t, and then there's obviously no P because the synode is not working at the moment. But this broad RS complex is telling me that, yeah, the ventricle did contract. And if I count the number of squares between the R and the R, let me just do this here activity, so that you are more comfortable with this. You see, it's a little more than, I would say, whatever I am writing, but I can say that this would be something in the range of about 3.5 to 4. I'll just increase it above. You can see some additional boxes present here. So I'm saying a little more than 3. So the heart rate is at least stabilizing towards 100, I would say, or a little less than 100. But my point is, from a person who is having a heart rate of 40, I am achieving a heart rate of 70, 80. That is pretty commendable. So transcutaneous pacing would ensure a sufficient cardiac output so that the perfusion of the heart itself and the perfusion of the brain of this patient will improve. And this is one of the main, I would say, technological wonders that we have nowadays, that for any patient with symptomatic bradycardia, the first line management would be to go in for, obviously, atropine, and apart from atropine we can go in for transcutaneous pacing as well. Now suppose in the question he says that the person is still not improving and what can be done subsequently, then your answer would slightly change. Then we'll go in for TVP, that is transvenous pacing. So there are two aspects which I want you to remember. I mean, the crux of the discussion, because whenever you're gonna read this topic, no, there's gonna be a big table given in the textbook, and the crux of the topic is that it's atropine. If it fails, it is TCP. If it fails, it is TVP, that is transvenous pacing. So I've just put that data on the record here. I'll just write that word once again, that if there is a worsening of the hemodynamic status of the patient, once again, I mean, that's the one of the indications for deploying a transvenous pacing. Now whenever you're gonna deploy these transcutaneous or transvenous pacers, they are giving electrical stimulation to the heart. Especially with a transcutaneous pacer, you're delivering an electrical stimulus via the muscles of the chest that goes down and stimulates the heart. So a lot of these patients might even be having fluttering in the chest when this pacer would be delivering an electrical stimulus. Whenever there's a fluttering in the chest, I mean, why I'm describing that is because, you see, to see whether your patient has improved or not, you need to check the pulse, and the usual pulse that you'll check is the common carotid artery. Now if there's a fluttering of the chest muscles, and there is even, the current will flow from the chest muscles to neck muscles also. The transcutaneous pacer is delivering electrical current, so it will cause fluttering of the chest muscles as well as fluttering of the neck muscles per se. So therefore, if you gonna check the carotid artery pulse of this patient, you may not be actually feeling the carotid artery impulse, but you might be actually feeling is the fluttering of the chest and the neck muscles. If there's fluttering in the chest muscles, it will be transmitted to the neck. And I said that if there's electrical stimulus causing fluttering of chest muscles, it can also cause fluttering of the neck muscles also. So the learning point at this, I would say on this slide next would be that to check out for the adequacy of perfusion, you usually go in for, or to check whether your person is responding to your treatment or not. Traditionally, the traditional learning is that you check out the common carotid artery. It is the carotid pulsations that must be checked, but I'm putting a cross over it to say that do not check the carotid pulsations in this patient. Yes guys, surprisingly, if he says that, I would say the surprising part is that all through the entire discussion in cardiology, I'll always say that check the pulse which is closest to the heart. Every time there is an inadequate hemodynamic status, how do I know whether there is an inadequate hemodynamic status, heart is not working, something wrong with the heart, I check carotid. But this is the first and the only time that I'm telling you that you in a general medicine question would be answering, check the femoral pulse of the patient to check out the response to the interventions that you're doing in this particular case, because carotid pulsations in this patient would be confused with the fluttering of the chest muscles or fluttering of the neck muscles due to the electrical stimulus that is being provided. Next up, I'll be explaining to you regarding the various permutation combinations that can be given to you in the exam with respect to a patient of bradycardia. In the first ECG that I've shown, I've already done the marking for the large square, so the heart rate of the patient is 60. I'm thinking to myself, is this patient having a sinus bradycardia? This person is having possibly a sick sinus syndrome. Let's see if he's having a sick sinus syndrome or not, because in sick sinus syndrome, SA node will malfunction, so P wave should be absent. But in this particular ECG, as you can see from the marking that I've done, P wave is being visualized every time. I have just marked the P wave every time. So because there is a P wave present, one thing I'm sure, this patient per se is not suffering from a presence of a sick sinus syndrome. There's a definitive P wave. Now the point arises, let me check out the PR interval of the patient. So I'll do some marking here, and you will notice that the PR interval of this patient is outrageously increased. The normal PR interval for any one of us would be 3 to 5 large squares. Let me just jot down the value for record's sake, 120 to 200 milliseconds. So the PR interval in a normal person is something in the range of 3 to 5 large squares. Let's do the counting here. I'm just going to zoom it in, and we are just going to do some basic calculation, though it's still obvious, but still let's do it for record's sake. If I start counting here the number of small squares, I have already told you heart rate is the only thing for large squares, otherwise it's always the small squares. And you can see that I'm counting almost 9 or a little more than 9 small squares to be present here. So 9 into 40, one small square is 40 milliseconds. 9 into 40 would be going up to a huge 360 milliseconds. I mean, that is the lower limit of the QT interval, what PR interval is present here. So this particular patient who's having a prolonged PR interval and presence of P waves obviously is having a first degree heart block. My interpretation from this ECG is first degree heart block. And let's look at where the problem is so that you are able to remember this on a long-term basis. The next part is just for explanation sake. Let me say this is SA node. The current has to go to the AV node, move down from the AV node into the bundle of phase, and then there would be ventricular depolarization. And let us now assume that my patient is having Ashkoff nodules. You can see that these Ashkoff nodules are, which I've shown symbolically in dotted red, would be slowing down the conduction. If the speed of conduction will become slower, there would be a prolonged PR interval in the patient. So the main diagnostic criteria for a first degree heart block is that there is no drop beats. Drop beats would be found in second degree heart block. There is no drop beats. There is only a prolonged PR interval in this patient. And this would be an outrageously increased PR interval, because of which exercise intolerance would be a primary complaint. You see, when you and me are sitting, suppose you're sitting comfortably, your PR interval would be 160. When you will exercise, suppose I ask you, doctor, can you do 5 sit-ups? Can you do 5 push-ups? You are young people, you can do that. When you will do sit-ups and push-ups, then your PR interval will become lesser. Yes, guys, PR interval in the ECG is inversely related to heart rate. So when you do exercise, when your heart rate will increase, your PR interval will become lesser. So in you and me, the PR interval can change. But if there is Ashkoff nodules, if there is fibrosis in the heart due to sarcoidosis, it may be a rare disease like endomyocardial fibroelastosis. If a fibrosis in these connections, then the variation in the PR interval is not possible. And if the variation in the PR interval is not possible, the person would be having is a exercise intolerance. So the ECG that I showed before you was for first degree heart block. Now let's compare this with the subsequent one, in which what I can pick up is a P wave. You can pick up the P wave in this particular case, and the difference between the P and the T waves is, which are shown in blue, is that the vertical height of the T wave would be about 5 millimeter in the limb lead and 10 millimeter in the chest lead. And when it comes to the vertical height of the P wave, it would be 2.5 millimeter. So the difference between the T and P is fairly obvious. There is a P wave present, but after that, I am literally waiting, and there is a flat line where there is a sinus arrest in the patient. This particular point of time, the person might put his hand on his pulse himself and might say, doctor, my pulse just disappeared. We are getting missed beats in the complained by the patient himself. He might just say dizziness, and you are checking out the pulse, you might pick up a missed beat. Or if it's an intelligent patient, he might himself say, sir, in between my pulse just disappears. So because there is a missed beat present here, what I'm supposed to do in this particular chap is that I'll pick up the P wave once again. You can see that P wave has been picked up, and then I'm going to count the PR interval, which is after the missed beat, and I'm going to compare this PR interval with the PR interval prior to the missed beat. You can see that there's a gross disparity. If you look at the PR interval after the missed beat and compare it with the PR interval before the missed beat, you can see from the arrows itself, I don't need to go into the counting part and just zooming it a bit into the slide. You can notice a disparity, or you can notice that the PR interval is unequal, because there is an unequal PR interval in this particular case before and after. Therefore, this tells me that this particular individual is suffering from second degree heart block, and this variation of the PR interval or the inequality means that the person is suffering from Mobitz 1 heart block. Now, there is another way to solve this question also. So let me just scroll down a little to the left to solve this MCQ for Mobitz 1 heart block. Another feature of Mobitz 1 heart block, which is usually taught in medical college, but I did not go ahead with that, is that you will notice a prolongation of the PR interval. If you compare the PR interval the first time versus the second time versus the third time, I'll just mark it once again. If you compare the PR interval the first time, compare it with that of the second time, compare it with the third time, there is a serial prolongation of the PR interval. Do not be under impression that you would get a missed beat only after 3 serial prolongations. It might be like 5, maybe 10, and then there might be a drop. So what I'm saying is there might be 5 gradual PR prolongations, then there is a drop beat, then there is 10 prolonged PR intervals, and then there is a drop beat. So it's not a symmetrical. It will always be asymmetrical drops that would be present. It could be like for 1 minute, no problem. The ECG is running perfectly normal. Then there's a drop. Then after 5 seconds, then there might be again a drop. So the drops that occur in Mobitz 1 heart block will not occur at regular intervals. They'll occur at irregular intervals. So it could be like 10 complexes, then a drop. 15 complexes, a drop. 3 complexes, a drop. 2 complexes, a drop. Like that. It would be asymmetrical. That would be happening. And the major point is that in an exam, in a pressure cooker situation, try to calculate PR interval 3 times would be a bit of a hassle, because when you calculate it for the second time, you might forget what was the value the first time. Therefore, my suggestion to you is that every time they give you, and most of the time they'll themselves mention this word missed beat in the question, and all you need to do is check out the PR interval before and after the missed beat, and this concept will become much more clearer if you compare this with the in ECG that is shown inferiorly, which looks almost the same. I'm just going to put a vertical green arrow once again to symbolize that this is the area where after the P wave there should have been a QRS complex. There is none. I'll just mark the P wave once again with red. I have marked the previous T wave with blue just for comparison purposes. And now what I'm doing is that I will be counting the PR interval or evaluating the PR interval after. Remember those words. Always check out the PR interval after and then compare that with the PR interval before. And in this particular representation, you will notice that the magnitude of PR interval or the duration of the PR interval before and after is almost the same. I'll just zoom it in for your convenience. The PR interval, if I count the number of small boxes, it looks almost visually the same. I mean, if you compare the two, the one on the top with the one inferiorly, in the superior one, there is the unequal PR interval. Here you can notice that the PR interval before and after is equal, which tells you that this particular chap is suffering from what is referred as a Mobitz 2 heart block. Both Mobitz 1 and Mobitz 2 are examples of second degree heart block. There's a fundamental difference between the two as well, that in Mobitz 2 heart block, the problem lies at the level of the bundle of his. Because the problem lies at the level of the bundle of his, an alternative term that is used to describe Mobitz 2 heart block is, he might in fact use this term multiple times. He might say the word infranodal. When I say infranodal, it basically means the problem is below the level of the AV node. That is, bundle of his is the one which is defective. Whereas when it comes to Mobitz 1 heart block, then Mobitz 1 heart block, the problem lies per se inside the AV node. So it is written as intranodal conduction block. These are some alternative terms that the examiner might be using. Intranodal conduction defect, Mobitz 1. If it is below the AV node, you call it infranodal conduction defect. I mean, that's where the defect is present in these patients. And though these two combinations are described even in the ECG in the arrhythmias component, I'm just making you revise this again. And even in November 2022 AnySet exam, Mobitz 2 heart blocks was asked. So most of the time in the exam, if they're going to ask you regarding Mobitz 1 versus Mobitz 2, both of them are examples of second degree heart block. Most of the time in the exam, the question that would come to you would be for per se Mobitz 2 heart block. Now, why is that so? I'll also explain to you in the next ECG that I explained. But prior to this, just get the orientation right. Every time you get a question with missed beats, just check out the PR interval before and after. If it is gonna be equal, it's Mobitz 2. If it is unequal, it's gonna be Mobitz 1 heart block. Once we get the data right, let's look at the subsequent ECG. In this ECG, as you can notice that I have already done the counting of the large squares, huge number of large squares present, almost 9 large squares present between the R and the R wave. So 300 divided by 9 would be something in the range of about maybe 30 something, right? So I'm just putting approximate value. I'm not getting into hardcore mathematics here. I mean, 9 forza would be 36. This is only 30. So I'm saying less than 40, something in the range of about 30-35 beats per minute. This means that the person is having some problem with respect to, I would say, the dominant pacemaker of the heart would probably be the bundle of his. I'm just assuming that because the maximum firing of bundle of his is about 40 per minute. Now let's check out the QRS complex. It's relatively broad. I mean, in each one of the previous discussions that I've had before you for bradycardia, I've not shown any slurring in the S wave. You can notice slight slurring in the S wave. It's relatively a broad RS complex which is occurring in this patient, even a broad S wave which is present. And now let us just see, is there a normal sinus rhythm present or not? So I'm gonna check out the P waves in this patient. Let me use an alternative color to describe the P waves. I can check out a P wave in this case. Yes, there is a P wave present. Then what's happening is that I can again pick up a P wave, which I put an arrow here. I can again pick up a P wave present here. So you can see there are two R waves, and I think that goes up is R. And prior to those R's, I am picking up P waves also. And there are two of P waves present. Now, normally that does not happen. No, after P, you do not get a P. After a P, you are supposed to have a QRS complex or at least a RS complex occurring. So in this particular case, there is definitely a heart block present, because if I check out the number of the P waves present in this case, you can notice I have counted much more number of P waves in the ECG of this patient as compared to the number of the Rs. In fact, if I just slightly zoom out, you can see that in the ECG shown, there are only 3 R waves that can be picked up, in contrast to 1, 2, 3, 4, 5, 6, almost 7 P waves that can be picked up. So the number of the P waves in this patient is not matching with the number of the R waves, which is a basic rule of ECG. The number of P should match with number of R waves. Because the number of P and number of R is not matching, this points towards etiology as complete heart block. Let's look at another aspect. In you and me, when we check out the PP interval and we compare this with the RR interval, in you and me, the PP interval and the RR interval is equal. Because if your atrial rate is 75, your ventricular rate will also be 75. You see, your and my atria and ventricle fire at the same frequency. But in this particular patient, one of the most important diagnostic features which I want you guys to remember is that the PP interval will never match with the RR interval. So there are two ECG criteria which I've said here. One, the number of P waves and number of R waves is not matching. That I've not written down because it's fairly obvious. And the PP and the RR interval is also not matching. Because of this, I would call this ECG as that of third degree heart block. In third degree heart block, the defect lies again in the AV node. The AV node is not functioning at all. If the AV node will not function at all, who will take over the heart? Bundle of his. Let me just give you a diagrammatic representation of this also, so that this becomes a permanent memory for you. Please pay attention here. Every time you're going to read the word third degree heart block in your career, this is the image that should come in your mind. The current comes from SA node, goes to the AV node, goes to the bundle of his. I'm putting a cross over this area to say that AV node is busted. Now, there can be various reasons for it, but the point is, if AV node will not function, then SA node cannot control the ventricles. So who's going to control the ventricles? The bundle of his. So in this particular patient, the ventricular rate is not decided by the SA node like in you and me. It is the bundle of his which is deciding the ventricular rate of the patient. And what is the max firing? Max firing of the bundle of his 40. You can see why I emphasized on the heart rate initially is a lot of these questions of bradycardia, you can pick them up on the basis of the heart rate value itself. That if the heart rate is going something in the range of over 30s, it means that most of the time it would be a patient who's having a complete heart block ECG given to you. Obviously, you need to deploy the remaining criteria, but my point is this particular patient, the PP interval, why I was saying PP interval is not matching with the RR interval, SA node will be firing at, let me say, 100. And ventricular rate will only be 40. Mathematically, atrial rate 100, ventricular rate 40. Atria would be firing 2.5 times faster as compared to that of the ventricles. So there is bound to be disparity. There is bound to be a AV dissociation. So third degree heart block is also written as complete heart block, or you might write the word AV dissociation. Tachyarrhythmia that has AV dissociation is ventricular tachycardia, but bradyarrhythmia, which has a AV dissociation, is the one that is being taught to you at the moment. Bradyarrhythmia with AV dissociation is a complete heart block, where the number of P is not going to match with the number of the R waves, and at the same time, you are also going to have a disparity between the PP and the RR interval. Now, I would like you to compare this ECG with the one that is shown inferiorly. In this particular ECG, what I'm noticing is, let me just mark out the P waves present here. Let me say this is P. This is a P wave present. And I can show I can mark out an inverted T wave here also. You can see that this is an inverted T wave, then there's a baseline isoelectric line, and then there's a P wave present. Now in this ECG, when I'm looking at it, what I assume is, or what I'm getting an impression initially is that after every P wave there should be a QRS complex. So there is a QRS complex after this P wave. There is a QRS complex present after a particular P wave, but there is no QRS complex. There is no QRS complex after this particular P wave. I'm just going to put a vertical line to say that this is assumed possibly the area where there are missed beats present in the patient. I'm saying missed beats because after every P there should be a QRS complex. I put these green arrows. Let me just change the color contrast so that's more obvious to you. I'm just putting this vertical arrow to say that this is the presumed time when RS complex should have occurred, but there is no RS complex present. So every time I get a missed beat in a patient, what I'm supposed to do is check out the PR interval before and after, and that's what I'm going to do once again in this patient. I'm going to check out the PR interval after the missed beat, and I'm going to check out the PR interval before the missed beat, and it's turning out to be equal. So the first impression of mine is that this person is suffering from Mobitz 2 heart block. In fact, Mobitz 2 heart block is the first interpretation that I'm making from this ECG, but it is wrong. Why this is wrong is because, and what I'm teaching you at the moment is a pure fact which is asked in the INISET exam, that they love to ask you about a differential diagnosis of Mobitz 2 heart block. I mean, this ECG can be misdiagnosed by most cardiologists as Mobitz 2 heart block, as I'm doing deliberately at the moment, but this is not a Mobitz 2 heart block. Now let me tell you what it is, and then I'll be able to explain to you this relatively better. This condition that I'm describing as a differential for Mobitz 2 heart block is called as 2:1 block. Now let's understand what he means by 2:1 block. What he means by 2:1 block is that there is one P wave that is conducted. So I'll just mark that one which is conducted. You can see that after P there is a RS complex occurring in the patient. So this area which I'm marking at the moment, because the P wave is conducted inferiorly downwards, so I'm saying conducted. But one P wave is not getting conducted. So meaning of the word 2:1 block is that you would be having alternatively, or let me just jot it down also, you would be having a conduction that would be successful. When I say successful conduction, P would be followed by a QRS complex, and then there would be no conduction that would be happening. And the query in your mind would be that, sir, I mean, it's unnecessary confusion, Mobitz 2 heart block versus 2:1 block. I mean, what's really going on? So first and foremost, what I want you to understand is that in Mobitz 2 heart block, now listen to my words very carefully. In Mobitz 2 heart block, what's going to happen is that there could be ECG where everything would be normal. You can see there is no prolongation of the PR interval in Mobitz 2 heart block. The PR interval the first time, the PR interval the second time, the PR interval the third time, it remains constant. So everything would be going normal. Then there's a drop. Let me say 3 complexes, a drop. 4 complexes, a drop. 10 complexes, a drop. But in 2:1 block, what I showed you was it is conduction drop. I repeat that again. In Mobitz 2 heart block, it could be like 10 complexes normal, then there's a drop. 5, then there's a conduction drop. There could be 2 conduction drop, 15 conduction drop, 100, then a conduction drop. So conduction drop is occurring suddenly after a large number of complexes. It is not like one conduction drop. But the second one that I've explained to you, the one that is currently on the slide before you, is slightly difficult to comprehend, but is the favorite of the INISET people. So my message to you guys is, every time you identify what is supposedly a Mobitz 2 heart block, check out the symmetry part. When I say the symmetry part, my point is, are you having an alternative conduction versus no conduction? Or are you having like 10 complexes normal? Or let me say in the ECG, they give you limited complexes, 3 complexes, then a drop, 2 complexes, a drop, 15 complexes, a drop. So if it is asymmetrical drops occurring, it's Mobitz 2. If it's an alternative one, as I've explained, then you would call it a 2:1 block, which is an important one from the INISET perspective. So these are the details that I would like you to remember for this topic, guys. You're doing a brilliant job by learning all these aspects, and I assure you the fact that this would pay you very well in your exam as well. Thank you so much for hearing me out.